Hello, and a very warm welcome to today's webinar, Shockwave Therapy in Equine Athletes, Injury Rehabilitation and Maintenance. Proudly presented by PulseVet in conjunction with ISELP, the International Society of Equine Locomotive Pathology. It is a great pleasure to introduce a panel of 4 highly accomplished veterinarians who will answer questions and share their experiences with us. A special welcome then to Dr. Ken Allen and Dr. Susan Johns, both of Virginia Equine Imaging. Dr. David Frisby from Colorado State University, and Dr. Sherry Johnson, Equine Sports Medicine and Rehabilitation, Texas. Thank you for taking this time to be with us. Now, I'll just ask each of you to give us a brief introduction of yourselves. Let's start in reverse alphabetical order today. So, Dr. Johnson, please.
Hi, well, first of all, thank you for having all of us. We've been all really excited to be on this panel, so thanks for the opportunity. My name is Sherry Johnson. I did my sports medicine and rehab residency at Colorado State University. I've since transitioned into a PhD program here at CSU looking at novel rehab modalities related to tendon healing. I do kind of wear multiple hats. I'm also affiliated with a practice based out of Whitesboro, Texas, equine sports medicine and rehab. We have a mobile practice that serves the Western Performance Horse, mostly the AQHA shows, and then also a rehab center. So kind of dabble in both the academic and the private practice worlds.
Great. Thank you very much, Dr. Johnson. Dr. Johns, would you like to tell us about you?
My name is Dr. Susan Johns. I graduated from Virginia Tech in 2002, and I joined Virginia Equine Imaging as a sports medicine intern. And I've actually been at Virginia Equine Imaging now for 18 years. I never left. And since 2015, I've served as the Land Rover U.S. eventing team veterinarian. So I oversee the care of the U.S. high performance horses at their national and international competitions.
Thank you very much, Dr. Johns. Dr. Frisby.
Hi, everybody. Welcome. And again, thanks for the invitation to participate. My history is, I won't go back as far as vet school. That may be more than anyone needs, but I moved to and started at Fort Collins at CSU in '92 and have worked there 3/4 of the time, mainly focusing on orthopedic research, both in the sports medicine and surgery realm, and then started sports medicine practice in the Western performance disciplines, of which Dr. Johnson is one of the people that has bought us out. So I'm now gainfully employed by one of our mentees, which is a phenomenal thing.
Excellent. Thanks, Dr. Frisby. And Dr. Allen.
Thanks. Appreciate the opportunity to talk about Shockwave, which is always interesting for me. I'm a Missouri grad. We don't get talked about much, so I try to talk about it as much as possible. And then for the first 15 years of my career, I was at Arizona Equine, and then sold that, moved out, created Virginia Equine Imaging in Middleburg, Virginia, and then have been here the last 25 years and had the opportunity to work with amazing practitioners like Susan, and had the opportunity to, my early days, work as a team veterinarian for eventing, and then went on, done a lot of work with FEI and USEF, and enjoyed all of it. So still hard at it. So back to you, Rod.
Thanks very much, Dr. Allen. And my name is Dr. Rod Richards. I'm Director of International Business and Clinical Research with PulseVet. I studied at Murdoch University in Australia, and I've been involved with Shockwave for 22 years. I can't believe I just said that, and it's a real pleasure to be here to be able to moderate this meeting. So now I'll put a series of questions to our panel. And remember, dear audience, you can send us your questions to the email address questions@pulsevet.com. Depending on time, I'll read out your questions. We will endeavour to answer those questions not covered on air per email in the coming days. So let's get started. First question is really for everybody. Describe your initial thoughts when first learning about shockwave therapy and how the growing body of information about shockwave therapy has changed how you utilize it in your practice. Dr. Allen, would you care to take that one first?
Sure. I had the opportunity to be introduced to shockwave actually at the 2000 Olympics in Sydney. And it was an unusual introduction to it. Not many of us knew anything about shockwave. We'd never seen a shockwave machine, almost all of us at that time. And as we learned more about it, I became more and more impressed. There's a story about me trying it on my knee and a lot of Australian Shiraz involved, but the bottom line is that I was impressed with the technology and what it might have for horses in the future. I came home, read up on the human literature, of which there was a body of evidence, and then became convinced enough to that same year purchase a shockwave machine of the high energy focused type. And then we've continued to use it now for the last 20 years and been very impressed. So that's kind of how shockwave, and now there's a lot of literature about it and a lot more information that's specific to the veterinary realm and horses. So have enjoyed following on with it over the years.
Great, thank you. Dr. Johnson, would you like to give your take?
Yeah, I am kind of coming at it from a different perspective than some of the other members on this panel, in the fact that I was kind of raised with shockwave therapy and the shockwave technology, meaning it was already in mainstream use by the time I had graduated veterinary school. One of my mentors at Iowa State University was Dr. McClure, so very much familiar with shockwave and using it and having been exposed to it. So I quite honestly don't know what it would be like to practice without it. So I, gained some experience with it through veterinary school, and then obviously that continued with my residency training under Dr. Frisbee and Dr. Donnell, where we, used it quite extensively and had appreciated some pretty impressive results in the clinical setting. So, the foundational work from a research perspective had already kind of been done by the time I entered clinical practice. So just kind of following up on that and still kind of investigating further uses for it has been my experience with it.
Very interesting take. Thank you, Dr. Johnson. No, good. Dr. Frisbee.
Yeah, well, I guess the other day when I tried to say that I started with shockwave in the mid-2000s, Rod, I guess you corrected me and said that it was a little earlier than that. But nevertheless, we had the fortune to start using it clinically and also do some of the first equine research with it. And, echoing what Kent has already said, it was a bit, at that time, it was a bit of an eye-opener, because when you went back to the literature, there was a fair bit of basic science that had been done. And in fact, at that time, there was a entire book that had been published on musculoskeletal shockwave in people. So a lot of that information kind of guided what came for us in subsequent years, which was, understanding how the horse was different, how many pulses one should use, which was a lot less than had been used in people at the time. So that's kind of my history. We've done multiple different research projects, all the way from looking at OA to tendon to effects on stem cells, and more recently a clinical study comparing shockwave to PRP for suspensory ligament pain. And we've done, as Sherry mentioned, it's a pretty big part of our sport horse, or Western performance horse, sports medicine type practice. We sometimes joke that you need an X-ray machine, an ultrasound machine, and a shockwave machine to be able to work in the field in sports medicine, at least with Western performance horses.
Very good. Thanks, Dr. Frisby. Dr. Johns.
Yeah, so in veterinary school in the early 2000s, it really wasn't part of our curriculum. But when I started my internship at Virginia Equine Imaging, it was something that we were using every day. And so it's really been a mainstay of my career for, goodness, the last 18 years. One thing that I think is interesting is that when we initially were using it, we primarily just used it on tendon injuries and hind limb proximal suspensories. And now we use it on a wide variety of equine injuries and in conjunction with other therapies.
Okay, interesting. Thank you. The second question also goes to all of you. Describe your most unusual case. Why did you think it might work? Did it? And what did you learn from it? Let's start with Dr. Johns this time.
Okay, so a case that stands out to me is when I first started to use the shockwave on equine poles. So I primarily deal with young thoroughbred 3-day event horses. And so this particular case came to us and it was having issues with connection in the bridle and avoidance behavior under saddle. And it was having low scores in the dressage phase. And so it came to us to see if we could help find a solution for that. And so after we radiographed the horse's neck and the pole, we were able to diagnose extensive remodeling at the external occipital protuberance of the pole. And at the time, there wasn't a significant bursitis in this region, so we didn't feel like injections would be particularly helpful for this case. And we had a colleague overseas that had been telling us that at their clinic, they had been using the shockwave, and this is probably 12 or 15 years ago, but had been using the shockwave on the poles. And so after we made sure that this would be safe and the horse would tolerate it well, we elected to do that on this particular case. And, initially I did it with some concerns that the horse may not tolerate this well with the shockwave between their ears, but we actually found that with a bit of sedation, the horse tolerated it really well. And more importantly, we had a good response to therapy. So that one stood out for me.
Brilliant. Thank you. Dr. Frisby.
Yeah, the case that I was going to talk about today was a bit of a learning experience for me. It was in the time where we were just starting to use stem cells. So that wasn't mainstream. And it was a horse that would go along relatively well, had a low grade lameness, grade 1, grade 2, and then would take the quintessential bad step and all of a sudden would be grade 4 and basically unable to work. And it was always lunging to the left. It was a very specific type of pattern when the horse would go sore, and it would take the horse about 2 weeks to get back to its low grade pain. And it was kind of a progressive piece to go down. We blocked it out and regionalized it to the Fetlock, blocked out to a low 4 point, radiographed it, didn't really see anything, blocked the joint, didn't really get any better. And it was a horse that was on the show circuit, so we saw it quite a bit. Long story short is we ended up doing a unilateral block and determining that it was on one side of the fetlock. And back then I wasn't too into ultrasounding fetlock joints, but that was one of the first that was a good yield for me because it had changes in its collateral ligament. And there wasn't really a whole lot of other options. Like I say, shockwave was the primary thing that was there. We shockwaved that horse after one of these times where it was grade 4. And instead of it taking 2 weeks for it to get better, it was better the next day. And it went on for about a month, had another incident, and we shockwaved it again. And again, in that time period, it was improved in a short period, i.e. a 24-hour period. And we ended up shockwaving it 4 different times. And in that time, the folks were home and they were unable to get at Shockwave when it was grade 4. And again, once again, kind of lending credence to it was a Shockwave that was helping. It also that time took another 2 weeks to get better. So we started more of a rehab protocol and Shockwaved it weekly, low doses for about a month. And we were able to follow that horse for 2 years after and never had any other incidents. So it was a learning experience, I would say, maybe not the most interesting case, but a different and a high yield one for the use of the machine.
Right. No, thank you. And Dr. Allen.
Well, mine was a case that, as usual, I learned a lot along with this one. And this was a case where it was a young quarter horse and it had a very promising career initially. And then it developed multiple leg lameness. We bone scanned it, did quite a workup on it. And the diagnosis that we came up with was inostosis-like lesions in the distal cannon of all 4 legs. And now inostosis lesions by themselves don't sometimes cause pain, sometimes they do. But and the way you in the end determine that is by you try to back everything else out, which we did. We did quite a little work on that horse, and trying to come up with something to use on it. And this was early days of, say, bisphosphonate therapy, so that wasn't really our first reach. And we weren't really initially thinking about Shockwave because we thought, well, that won't be very effective just doing it in the distal cannon and joint area. But we didn't have many options. And the people were concerned that we press on. And so Dr. Johns and I shockwaved this horse and did it repeatedly. And repeatedly, the horse became sounder and sounder every time we did it. And then in the end, they took that horse back. It went back into competition and won the world championship in its age division and competition division that year. So we were very impressed with ourselves, even though we had no idea how we did that. But we were very impressed with Shockwave and the outcome in the process.
Wow, thank you. 4 very interesting cases. So let's move on. When do you consider shockwave therapy as the primary treatment modality? And when is it part of a multimodal approach? Describe some indications that frequently benefit from a multimodal approach, and what part does shockwave therapy play? Dr. Johnson, could you take this one first, please?
Absolutely. I would say that the bulk of my experience with shockwave therapy within the rehab setting specifically is coming at it from a multimodal approach. And our main indication is trying to promote a more pain-free state so that we can safely and comfortably begin a physical therapy program with that horse. And many times the first phase of our rehab is to kind of deconstruct the whole scenario, the whole situation that the horse is in. So taking out the interaction of the rider, taking down the intensity of the work and all of the specific maneuvers, you know, whatever that horse does for a living, we deconstruct the whole scenario. And then you still have this very painful patient, you know, for a variety of reasons. And some of that may be neuropathic in origin. Had the opportunity to work with Dr. Reed on several post-op cervical stabilization cases. I've found shockwave to be extremely beneficial in those cases for when, you know, the surgery has gone successfully, everything is stabilized, but we still have some arthritis or we still have a residual lameness because of it. So I use the shockwave more often than not as part of the multimodal therapeutic approach to really get those patients kind of over that initial hump and out of kind of what I call the cascade of despair so that we can comfortably begin the physical therapy program with those horses and have had very good success. It's actually an integral part of a lot of our rehab programs.
Thank you. Brilliant. Dr. Johns.
Yeah, so I looked at this question a little bit differently. So when we were talking about when I would use it for primary therapy, so certain pathologies that we tend to use it as a primary approach would be for things like addressing arthritis in the pastern or ring bone. We talked about earlier, like shockwaving, remodeling of the pole. Also, we'll use it in a first line of defense if we feel like the horses are no longer responding to interarticular therapy of the lower hock joints, and we'll use it to address tarsitis. I also use it as a primary approach when I have competition horses that can't have a long period of time off, and so we may not elect to do more invasive injections, but we would use shockwave. And then in terms of when we use it in combination with other therapy, at our practice, we do a lot of nuclear scintigraphy and we do the follow-up workups and treatments the next day. And in a lot of those cases, the horses are going to either have the multiple limb lameness or potentially a primary hind limb lameness, but also an axial skeleton issue. And so in those particular horses, we may need to, you know, inject the lower hock joints and front coffin joints, but also address back pathology. So we may elect to do injections of the hocks and coffins, but elect to use shockwave on the backs or the neck because we're limited in the amount of steroid we can use on a given day. So in those cases, we oftentimes will use shockwave in conjunction with other therapies.
Great, thank you very much. The next question, describe, and it's a question primarily directed to Dr. Allen and then to Dr. Johnson. Describe your experience using shockwave therapy with other regenerative therapies. How has that changed over time? And there are numerous references. Dr. Allen, what would you say to that?
Well, there are various things out in the literature about this. The one that was probably the most striking to me and kind of changed the way we do things was Katie Sebaugh's paper when she was at Georgia. And that showed a variety of effects that were happening following shockwave with PRP injections. And since we use PRP extensively in our practice for both soft tissue and various joint issues, it was very interesting. I actually talked to Katie about this and was very convinced that it was worth following on with. And so we do that fairly routinely in our practice nowadays. We'll do a PRP treatment and then follow it on with shockwave. And we feel like we're getting the benefit of stimulating the alpha granules and the platelets and getting some upregulation of the cytokines. So again, there's more and more science about it. I know just recently I looked at a pre-publication paper in Human where they don't use as much shockwave as we do, but now they're starting to consider this as well.
Thank you. And Dr. Johnson.
Yeah, I kind of, you know, in contrast to Dr. Allen's experiences with it, I don't so much combine the use of the regenerative therapies or the biologics as much with the shockwave therapy. I really more view the shockwave therapy in the shorter term setting and the biologics more of like the long-term game. So I don't, you know, nearly as commonly use like the PRP and the shockwave together as what Dr. Allen was describing. Rather, I would say my approach has been more using the shockwave in the short term, kind of breaking that pain cycle and getting things started and initiated from a tissue healing perspective while my biologics are processing or growing.
Okay, thank you very much. So this question is aimed primarily at Dr. Allen and then Dr. Frisby. Virginia Equine Imaging has presented a retrospective review looking at long-term success treating suspensory ligament injuries with shockwave therapy relative to surgery. Please share your thoughts and any update on thinking. Dr. Allen.
Yeah, this was a presentation that I presented actually Amy Norville presented for the practice. And what it involved is it was an outcome study looking at comparing surgical fasciotomy, which is primarily what we did surgery-wise at the time, and then shockwave. And there had been some previous papers that were kind of questionable about whether or not shockwave was helping the hind limb proximal suspensory ligament with a desmitis. And we felt very comfortable that it was helping clinically, but decided to go ahead and work on a paper and a presentation that would prove that. And then when we got done, what we found out is actually the outcomes were almost identical. They were both positive, but they were very similar. And then since then, this has, again, more work has been done in this regard. And I think what we've found is there are alternatives to doing surgery with this and more invasive practices. And so it's worthwhile considering it as a primary treatment for particularly hind limb, but all limb proximal suspensory ligament desmitis.
Thank you. Dr. Frisbee.
Yeah, you know, my experience is I haven't had the opportunity to have the nice direct comparison that Dr. Allen's group has put out there for us. I would say the horses that I operate, and I typically would do a neurectomy, fasciotomy when I do it, have all failed shockwave. If I have anything to say about it, meaning, you know, for us, surgery is almost always the last resort, and we'll manage them with shockwave. And often, if shockwave has not worked, we'll try PRP as a second line. And when those two have failed, then we'll go to the neurectomy, fasciotomy. So it's a little bit different population and how we get to the surgery piece of it. Yeah, in the end, I would say, you know, we're probably at about the same 80 to 90% with the surgery, with selecting that way. But again, you have to understand that they're all have failed the other more, or what I would consider easier medical management.
Okay, thank you very much. This is a bit of a follow-up question to the previous one, and it's primarily for Dr. Johnson and then Dr. Johns. With regard to treating PSD, what are your thoughts on treating a standing versus a flexed limb? Can you think of other indications that benefit from specific positioning? Dr. Johnson.
Yeah, I actually have found, or as much as I can, I try to shockwave both the front and the hind suspensory cases that I have in a non-weight bearing or a flexed position. And I do feel like subjectively I can push some of the flexor tendons out of the way. You know, I can actually get the probe closer to my target tissue area. And as long as the patient is compliant with it, you know, it's a safe situation, I will definitely try to go for that. Additionally, a couple of other things that come to mind that I do in a non-weight bearing or a flexed position would be Fetlocks. So targeting that medial condyle, and also stifles, which can get a little bit tricky from a patient positioning handler overall scenario, but it can be done. And the stifles, I feel like I get better access to the weight-bearing surface of the medial femoral condyle. The meniscus moves just subtly, and I have better access a lot of times to the damaged area, the site that I'm really trying to target. And these things, you know, when you're thinking about how we image and how we ultrasound and the position that the limb is for us to get the best image possible and to move things out of the way, that non-weight bearing position helps tremendously with that. So that was kind of the genesis of the thought process behind some of those things. And, you know, especially with the stifles and the fetlocks, you can really access that weight bearing portion a lot more in a non-weight bearing position. So I would say those are the top ones that I do differently than just the standard weight bearing. If the patient's not compliant and it doesn't make sense for the situation, certainly doing it in a weight bearing position I think is also acceptable. But I do try as much as possible to take advantage of that scenario.
Okay, thank you very much. Dr. Johns.
I have to agree with everything Dr. Johnson just said. The only thing I'll add is, oftentimes I'll have horses that can be a bit uncooperative. And so in some cases, I will flex them just from a safety perspective. It's safer for the horse and for the staff involved. And then 2 other areas of pathology I find that the horses are really reacted to that benefit from having the limb in a flex position, oftentimes really acute splints. I find horses to be quite reactive to the probe in those areas, and I always find that it's easier to hold the limb up. And then also I find for acute suspensory branch injuries, it seems to be a bit easier to have the limb unweighted to address that area as well.
Okay, thank you very much. So this question is primarily for Dr. Frisby and then Dr. Johns. And I think you touched on this earlier, Dr. Frisby. Equine Sports Medicine and CSU published a prospective randomized study comparing PRP and shockwave therapy for suspensory pain in the Western Performance Horse, published in 2019. Please share your thoughts and update, Dr. Frisby.
Yeah, this was work that we started because of our own clinical questions. It was interesting when PRP kind of came in to clinical practice. We had shockwave and we had a majority of horses that seemed to respond to it, but there were some that were non-responders. And when we had both modalities, we spent quite some time debating and maybe even arguing about how you decide when to use one modality versus the other. And that was really the genesis of that particular prospective study. We see a lot of proximal suspensory injuries, and our clinical acumen couldn't figure out when or how we should be choosing these modalities. So that's the genesis of it. In the end, what we found was horses, if you took all of the horses that had suspensory ligament issues and you put them together and you treated them with shockwave, versus PRP, I think it was 3.8 times more likely to have those horses in work a year out. So that was kind of our impression, meaning if it was a coin toss for us and the owner didn't have any opinion, we would definitely start with shockwave. And I think that study borne that out. The thing that was a bit of a pearl that we certainly hadn't realized is we were ultrasounding those cases, of course, at the time of diagnosis, and horses that had grade 3 or grade 4 or more significant ultrasonographic changes did tend to do a little bit better with the PRP long-term compared to the shockwave. So that has changed it. So again, without any ultrasonographic changes, we would always go with shockwave kind of as our first line of treatment. And then we would consider other modalities with the more ultrasonographically abnormal suspensory ligaments. So that was kind of my take-home message of that study.
Great. Thank you, Dr. Frisby. Dr. Johns.
Yeah, so the only thing I'll add is with our English sport horses, we found in our clinic that the horses that tend to present and they're a grade 2.5 or less, we find that those horses do really well with a series of shockwave therapy. But what I found was some of like the 3-day event horses that have had a traumatic injury on course and present with a hind limb proximal suspensory that's like a grade 3.5 or worse, oftentimes I feel that those horses are better served to do a combination of PRP and shockwave, and if they're not responsive, then typically those horses we send on to surgery.
Great, thank you. Question number 8 is aimed primarily at Dr. Johns and followed up by Dr. Johns. Virginia Equine Imaging has presented on the treatment of chronic back pain, 2010, I believe. Share your thoughts and any update on thinking. Dr. Johns.
Yeah, so the basic principles of this presentation at AEP in 2010 are the same. So we are still very committed to doing a detailed clinical and moving evaluation when the horse presents to us, and using advanced diagnostics to very specifically localize the pathology. In this presentation, we talked about shockwave therapy, administration of bisphosphonates, ultrasound-guided injections, and mesotherapies as our mainstays for treating chronic back pain. And I would say we have a similar approach now. I would say the one thing that has changed a bit, and obviously there's varying opinions about this, but we are oftentimes using ultrasound-guided injections of the biologics versus the steroids now. And in almost all those cases, we're following them up with shockwave on the back. Dr. Allen, do you have anything to add to that in particular?
No, it's been surprisingly effective. We actually didn't expect it to be quite this effective. We're in the midst, because we have a large number that we've injected corticosteroids, and then a large number that we've injected PRP, and we're trying to go back and do a retrospective study about the outcomes on that.
Great. And Dr. Johnson?
Yeah, just to follow up on that, in my opinion, the shockwave therapy has been one of the most effective tools that we have in managing axial skeleton pain, whether it's an actively competing horse or it's within the rehab setting. So from working, the trenches of the quarter horse shows, the horses that are presenting, they may have either chronic back pain or it's an acute on chronic situation where the horse is preparing extra hard, things like that. I've found that shockwave is actually more effective for me than an injection or a medication in breaking that initial pain cycle. From the rehab perspective, those horses that come in with, say, a stifle injury, or they're recovering from a post-op stifle arthroscopy, I find that they typically get secondary pain and restriction through their middle gluteal trigger points, the cranial aspect of the tubercoxy, all of those muscle groups that insert there. And so the shockwave, whether it's primary back pain or it's a secondary referred type of pain, I think has been an extremely valuable tool that we have in our toolbox to help get those guys more comfortable.
Great.
Probably just an add-on to that, Rod, if I could.
Sure.
One of the things that surprised me when it came to injecting SIs is some of the horses that, tend to grade things on a 0 to 4, where 4 is the most severe. Horses that come in with a grade 3 or grade 4, often I will inject their SIs. And that typically won't get them sound, but provides, if they do improve, it provides some indication that you've at least localized an area of pain. And then often following up with the shockwave, as Sherry said, more for the other regional things you probably don't get with the injection alone. Those horses often then go sound with that. So I think that, that would be one. I guess that's multimodal in a way, but I think that type of therapy, as Sherry said, it's a phenomenal tool that we have for a lot of that nebulous lameness that you may not actually be treating the primary thing, but the secondary piece is causing a lot of discomfort, and the horse is not able to compete until you've relieved some of it.
Great answers to that question. Brilliant. Thank you. And the next question is primarily for Dr. Frisby and then Dr. Allen. And you might remember this, Dr. Frisby. CSU published a paper investigating the effect of shockwave therapy versus control and intramuscular PSG for osteoarthritis, utilizing their bone chip fragment model, published in 2009. Please share your thoughts and update on thinking.
Yeah, so that was one of the first kind of controlled experimental studies that we'd done, and really looked at the OA side and the horse. And, the genesis was, as you went back in the literature on the human side, you were having people that were getting treated for kidney stones that also had hip pain, and the trajectory that they were doing the shockwave netted shockwave energy hitting the hip on one side. And those people were reporting that, yeah, their kidney stones were good, but their hip pain on the side that the trajectory would have taken the shockwave that way was better as well. And that kind of led to the OA indication of shockwave. So, you know, we followed that up and we saw various parameters as far as symptom modification that was significantly improved with shockwave. And our belief was we were getting most of the effect at the joint capsule and in the joint capsule itself. You know, the mechanisms weren't as clearly delineated in those days as they are now, but that particular hypothesis, I think, is at least supported by what we know, you know, in the last 11 years anyways. So it seems that by directing the treatment, which is what we were doing really kind of at the joint capsule and joint capsule attachments, we saw a reduction. There was also a reduction in the total protein, which is a good indication of inflammation in the joint as well with shockwave. All of the effects that we saw, somewhat surprising to us, were better than what we had seen with IM Equine. And in fact, that particular study kind of halted me from using IM Equine. I still use it in the joint commonly, but that comparison was good. And I think that that's another period. And I think Susan indicated with the ring bone cases, I think that non-articular pain that you get that you can't attack with a steroid injection, I think the shockwave does really well and can be additive in a lot of those cases.
Great. Thank you, Dr. Frisby. Dr. Allen.
Well, just echo what Dr. Frisby said, is that it certainly has proven over the years effective in osteoarthritis. In a variety of different areas, capsulitis and the neck facets. We'll inject the joint sometimes there, but the capsulitis is causing part of the pain. And so follow that on with shockwave, and certainly you get a more effective management of that horse's arthritic areas. Some of the early papers in veterinary medicine were on hock arthritis. I would tell you it hasn't changed. Are using interarticulars in hock arthritis as the primary way, but certainly as a secondary or multimodal, or sometimes where interarticulars have failed, there's a real use for shockwave in that, as in joints as well as the back, which we've talked about earlier.
Great.
And I would
Thank you
just
very much.
follow up on that, Dr. Allen. Those horses that are undergoing the process of distal tarsal ankylosis, they're trying to fuse, they're crazy painful going through that fusion process. I actually think that the shockwave therapy and getting those horses across that pain threshold is more effective sometimes than the intra-articular medication. But using the two together has been really beneficial.
Fantastic.
Not to dip into our later questions, but for the people that maybe aren't as familiar with that particular paper, when we talk about the symptom modifying side of it, realizing that we're talking that there are symptom modifying effects months after the last shockwave treatment. So likely, I interpret the literature like there's a potential for a 48-hour analgesic period after the shockwave, but not a long-lasting one. So the effects that we were seeing were in fact long-lasting in the terms of months to past that. So, and I think a lot of what we're seeing of these symptom-modifying effects of shockwave when it's used on the joint are far-reaching and wouldn't be considered just a temporary analgesic side of it.
Great, thank you. And that segues nicely onto the next question, actually, which is primarily for Dr. Allen and then Dr. Frisby. The phenomenon of post-shockwave therapy analgesia is controversial. What thoughts and concerns can you share about the analgesic effects of shockwave therapy. Dr. Allen.
Well, and this has been looked at by a variety of different organizations. Most of the science on it is based on Scott McClure's original work that he did, where he showed a profound analgesia, but it was very short-lived, 2 to 3 days. And then, you know, what Dr. Frisbee is referring to is that longer effect, which is not profound analgesia, but is certainly helping the pain and helping that horse get back to a more realistic performance status. So a variety of regulatory bodies have looked at this over the years, and two I can speak about. One would be FEI, and the other one would be USEF. I've been involved in the conversations on how we wrote the rules for that. FEI's approach to it was to take the science, give themselves a safety margin. So they selected 5 days and then say, all right, well, we're going to recommend you not do shockwave on these horses, and that you cannot do shockwave within the FEI compound. And the FEI competition, you're able to control that compound very adequately. So there's a rational rule based on the science. USEF came at it slightly differently. They don't have quite as good control of the compound as FEI does. But what we went back to was, again, looking at the original work and said, well, we're going to select 3 days. And then there was a discussion and a compromise on the back and pelvic area that actually could be shortened to 12 hours. And so in the end, that's how we settled on the USEF rule. And then we mentioned that if you have to sedate the horse, that is separate. You have to go ahead and deal with the sedation aspect of whatever that regulatory body's rules are. And I would take a moment to point out that the adult Western or English performance horse is not the same as a juvenile racehorse racing at speed with concerns to potential catastrophic breakdown. That risk is practically nil in the adult performance horse. It's very low, and it's really not in the areas that we're talking about treating. And so that's why I think it was good that both these organizations were able to go back to the original science, come up with a rational rule that has now worked for numerous years within those regulatory agencies.
Great, thank you. Dr. Frisbee.
Yeah, I alluded to it, obviously. I also would say, I think the publications that McClure and others have put out there on the analgesic properties lasting for around 48 hours is certainly what we see clinically. And I also will say, you know, in my clinical experience, I've not seen any ill effects of shockwave, meaning a horse that we've shockwaved and then has gone on to come up with a worse injury than it had before. And I somewhat presented the case at the beginning because that was a case that I was actually quite scared of. I thought, you know, if there was a case, because the horse got so lame, and then when you shockwaved it, it got so profoundly good. If there was a case where shockwave was going to mask something, the horse was going to go on to injure itself more. That was probably the case I was going to see it in. And I think that typifies, in fact, what I haven't seen, but rather the opposite, is they go on to be more stable and heal. And I would agree. I applaud FEI and USEF for using the science and the rules that they've come up with. I think they're really quite reasonable and workable when you're in the trenches. doing it. So it's great to see organizations doing things that way. And the thoroughbred racehorse is different, of course, because of what Kent said. The risk for fatality to the horse and not only the jockeys is higher, and we would expect a more conservative timeline just based on those factors alone, if nothing else.
Great, thank you very much. So the next question is really a bit of a follow-on to the previous one, and Dr. Johnson, it's for you primarily, and then Dr. Allen. Following on, recent publications have demonstrated that some specific mediators could be used as markers of shockwave therapy in horses. What are your thoughts on this?
Yeah, I think that's a great question. And, kind of the genesis of that question originated, there was a really nice paper that came out of Penn that was recently published in EBJ, with the genesis being, are there specific biomarkers that are capable of detecting when shockwave was performed? Or said differently, are there differences in inflammatory mediators before or after shockwave therapy? And the authors looked, at beforehand, and then also the application of a single application of shockwave therapy all the way out to actually 21 days. And the authors looked at about 10 different inflammatory mediators, and they found that the plasma concentration of 5 of those were actually changed following shockwave therapy. And interestingly, those were IL-1 beta and IL-6 that were downregulated, while TNF alpha, IL-1RA, and TLR2 were actually upregulated. So while that's given us good insight into things that might happen in relation to shockwave therapy, we're still not able to conclude a definitive biomarker relationship as a result of that work. So it was definitely a good start, a good first step in that. But there's a lot of things within the body that can cause those inflammatory mediators to change. So we're not actually able to say that, yes, it was definitively shockwave therapy that changed those inflammatory mediators. Interestingly, I thought that, the IL-1 beta being decreased and IL-1RA being upregulated, those are both good things. They fit into the category of how shockwave therapy produces such a potent analgesic effect, which is great. And we still also don't know the effect of the dose of shockwave, the tissue application. So what tissue are you focusing it at? The age of the horse, the presence of orthopedic disease, what exercise level are they in? Are other medications being used in conjunction with that? Like, there's a whole other spectrum of things that, we don't really know how that interplays with the inflammatory mediators and shockwave therapy. So again, we are all operating under the blanket that, shockwave therapy needs to be used under veterinary prescription and in accordance with your jurisdiction's guidelines. And we all want to see the use of shockwave therapy still being used in that appropriate way. So we're just not able at this point in time to have the smoking gun biomarker relationship. And I don't know if any of the other panelists have any other thoughts on that as well.
Thank you for a very detailed and thorough answer. Dr. Allen.
Well, and there's been some work in Europe in this regard too, looking at biomarkers. There was a French paper, and it came to largely the same conclusion that you've nicely described on the Penn paper, is that certainly there are biomarkers that are being upregulated and downregulated, but can we say without a shadow of a doubt, like we want to in a regulatory agency, that is unique alone to shockwave? And the conclusion I can tell you from sitting in meetings and with the regulatory bodies on this particular question, at least in FEI and USEF, is that they're not convinced that that would be definitive enough to base sanctions upon. So it's interesting work. I think it will continue to be followed and continue to be worked on, just as you're describing. But I think for an agency to base regulatory sanctions on that right now might be premature.
Great. Thank you very much. So the next question is primarily for Dr. Johnson and then Dr. Johns. We know that treatments where the focal area impinges on periosteum and bone are painful, whereas treatments involving soft tissue alone is usually well tolerated. What are your thoughts about sedation for various indications? Dr. Johnson.
I, to be totally honest, don't have to sedate many of the patients that I am using shockwave therapy for. Certainly there's outliers to that. Those horses that are either painful or just bad actors to begin with that aren't going to allow you to do it without sedation. But for the most part, I would say 80–90% of the time, I'm not sedating the horses in order to perform the shockwave therapy. Additionally, you know, some of them have competition medication guideline withdrawals that we're trying to respect. So those actively competing horses there, not certainly utilizing it. The two things that I think are the most likely to require sedation with the use of shockwave are those really, really painful splint bone exostosis horses, or the buck-shinned horses that just, I mean, you lay your hands over the area and they kind of want to jump out of their skin. So that would be the number one. The number two would be the cervical pain horses. They can be quite painful over direct application in that area. And so oftentimes, you know, for those two specific indications, I would say that's what I've had to sedate horses most frequently for in order to perform the shockwave therapy. But most of the time it's extremely well tolerated, especially in the soft tissue setting. And a lot of times I don't know that it's particularly the shock wave itself that's painful, or it's just the orthopedic problem in general that the horse has gotten a mental thing around that. So, so yeah, I think that about sums it up.
Great, thank you. Dr. Johns.
Yeah, so my experience is a little bit different. The population of horses that I work with are usually quite noise sensitive and very fit, typically thoroughbred. So I would say actually the majority of cases that I do does require sedation. One area that I really don't like to use sedation with or use very minimal sedation is when we shockwave the back. I really like to gauge those horses' response to the probe placement and just their generalized reaction. And oftentimes it'll dictate if I'm going to do more pulses with like the 35mm probe or the 80mm probe. And then I just like to correlate to see if it is matching with the areas of pathology that I've identified. But for me, a lot of times it just comes to protecting the horse and my support staff. And so in a lot of cases with the population of horses that I deal with, I do feel like I have to use some light sedation.
Okay, great, thank you. We're running out of time, guys, and we're going to skip a couple of questions. But in the meantime, we've got a question in from the audience. It's a good question. And because of the nature of it, I think I'm going to ask the person with the longest experience with shockwave, which is Dr. Allen, I believe. The question is, radial pressure wave are also called shockwave. What is your experience with this compared to focused shockwave?
Well, in the early days of shockwave, there were the first papers out, and both in human and in veterinary medicine, were using radial shockwave. Again, I was introduced initially to the focused high energy shockwaves, and that's what I became interested in. And so before I purchased a machine, I went back and read the human literature that was available on radial versus high energy focused shockwave, and was fairly easily convinced that the way to go was high energy focused. And so that's the direction I went, interestingly enough. And then about a year or two after I had purchased that machine, I was asked to do some consulting for a group of insurance companies, and they wanted to know about shockwave, and I laid them out this same research And that's why in the American industry, the focused high energy shockwave is paid for by most insurance policies, and the radial is not, was based on that initial information. So that's the story from way back when in the dawn of time.
Thank you. We remember that well, both of us.
Right.
Anybody else have a comment to make? Dave?
Yeah, I would make a comment. You know, early on, I was helping in a practice that only had a radial unit. So it was interesting because that's what you use, because that's what they had, right? And my comparison was really only around suspensory ligaments. But I think, you know, in the short term, meaning in the first couple of days, I saw relief with the radial unit, but I didn't see the kind of prolonged relief that I was seeing kind of in my practice, if you will, with the focus unit. And I won't belabor the point, but as Kent said, I think once you start looking at the science behind it, it's there's a lot of support for a high energy focus unit in comparison.
Great, thank you very much. Final two questions, and we're going to whiz along a bit. This is for Dr. Johns and then Dr. Johnson. In your experience using shockwave therapy, what final key tips would you give to a student about trode placement and movement, energy settings, trode penetration depth, and or treatment follow-up? Just what are your most important take-homes on that? Thank you, Dr. Johns.
Well, two things that Dr. Allen taught me early on is, one, when I'm out looking at horses ambulatory, is to pull out my ultrasound and just put it on the area of pathology that I'm concerned about, and it really helps me gauge exactly where I'm going to put the probe, and also it allows me to determine the type of probe that I should use, so the appropriate depth. And then the other thing that I learned is, oftentimes when we're shockwaving these horses, we do it at we do 3 treatments at 2 to 4 week intervals. And I would just encourage young graduates that instead of just like on your second and third treatment, instead of just going out there and performing the procedure, to really take that opportunity. For instance, say you're shockwaving a tendon for your primary clinician. Take that horse out of the box, palpate that tendon that you're treating, jog the horse up and back on the straight, do a flexion, and really make certain that you're getting the response that you want, because it could be an opportunity for you to change your protocol so that you have a good outcome. And then the only other thing I will say, just from a practical point, is that I would highly encourage young graduates and practitioners to use ear protection. So we just go to Home Depot and we get the ear protection like that's used on construction sites and things like that. And I do so much shockwave that I wear it every day. And I also have one for the client to put on while we're doing the procedure. And it's something that I think has been valuable since I've started using it years ago.
Great, thank you. Dr. Johnson.
I think all of the points that Dr. Johns made were kind of along the same lines as what I would advise someone to do. I think the patient follow-up is critical. One thing that Dr. Frisbee always instilled in me was, reassessing those horses. And if you're not getting the response that you're expecting after that first or maybe second shockwave treatment, you may need to go back and dot some more I's or cross some more T's and just really make sure that you're not missing something from a diagnostic standpoint. So understanding, that it is a modality that can be really, really beneficial in certain settings and used appropriately, but, always have that little voice in the back of your head, being inwardly critical in terms of that patient response. And I think that the ear protection is a great thing, Dr. Johns. I'm glad you brought that up, because we have actually started using that as well. It gets very loud. And I think that from a general safety perspective, that helps. Similarly, we don't offer ear protection for the horses, but for those horses that are very sensitive to the noise, we do sometimes use earplugs in those horses when we're doing it, and that's to facilitate safety of the whole entire process. So always thinking outside of the box, always thinking about safety and compliance. and how we can most successfully accomplish everything. But yeah, it really has been a great tool in our practice. Through my training and all through my career has been a heavily utilized tool that I would probably be a little bit lost without.
Great, thank you very much. Right, I'm going to sprint right through the last question, which goes to the mentors. So, Dr. Allen and Dr. Frisby, what have you learned from Dr. Johns and Dr. Johnson about Shockwave? You can pick. Let's go Dr. Frisby first.
Well, I would say I've learned a lot of things from Dr. Johnson, just in general, but if we'll go down to the Shockwave side of things. You know, I think Sherry's multimodality, use it to get those horses feeling better, being able to mobilize them more, and then build their strength up is definitely something she's pioneered in our practice. And I can still remember a case where I had historically not used it on a lot of stifle cases, and I'm not really sure why, to be totally honest, where she was like, oh, you really need to shockwave that stifle, and we were at a show, and lo and behold, it worked really well. And it was you know, a new tool in my toolbox for stifle issues that are not responding to medical therapy.
Great. Dr. Allen.
Well, I've had the opportunity to work with a lot of fine young veterinarians, and with Dr. Johns being one of the best. And it was always nice for me to see that she was able to go on and take my old job that I did long ago, doing the teamwork with the event horses, and I think take it on to the next level, and looking at those horses in detail, and sometimes a detail that she could point out to me that I was missing. So what I've learned over the years and working with very smart young veterinarians is that to encourage them to always feel free to have a collaborative discussion. I always learned something. Never apologize for being the smartest person in the room. And as my dad told me once long ago, Kent, you should never miss the opportunity to shut up and listen. And so I try to listen to them every time I get the opportunity. So that's what I can tell you.
Thank you very much. I have to say it's been a huge amount of brilliant information on a subject which is also dear to my heart. And I'm sure the audience has got a massive amount of take-home messages from you all. I know Dr. Frisby's in a rush. I just want to thank you all very much personally and on behalf of PulseVet. And I really hope we get to meet up again, probably at AEP. And so I wish you all the best. Stay safe. Thank you very, very much. Bye-bye.
Thanks, Rod.
Thank you.